I'm fine, thank you. Здравствуйте. Это самый дисциплинированный, самый интересующийся наукой ребята. Это первый курс. Молодцы. Будет еще, нет? Время еще есть. Ну, арабы знаете сами. Может быть, фотографии сделать. Давайте фотографироваться. Ближе так. Пока есть время, давайте. Я, наверное, буду так, что ли, как будто... А меня вот оттуда нельзя снять, как вот так под углом, чтобы и их, и меня захватить. Получится так? Спасибо. We'll have memories. Not very good repetition. А так студентов не видно. Темно, да? Может быть, там мне поиграть с подсветкой? once again until the lecture begins. Sorry for disturbing you. Спасибо. Thank you. Еще раз видео. Что, послезавтра же еще? Да. Осанка мне нравится. Послезавтра, может быть, вы даже встанем так после лекции все вместе. After tomorrow, we'll have a picture together. We will stand all together. This is very far away. Faces are not visible very well. So come. The last lecture will be the most interesting one about the complementary and alternative therapies, including vitamins, minerals, and herbal preparations. Because they are very popular in prophylaxis and some people are using for the treatment. So we'll discuss what is their place currently. Не обязательно. Просто если они сказать, что не смотрят. А сколько онлайн у нас видно, нет? Очень мало, по-моему, да? Не видно. Это онлайн хорошо подключается. А на прошлых лекциях было хорошее количество. Да, подключается, не слышу. Ну, они не жалуются, что я не вижу комментариев. Понятно, непонятно, может, слишком сложно. Слишком много. Говорят, я вот ссылку еще раз сейчас всем отправила. Ну, вот они сказали, что им интересно. Did you fill the questionnaire? I've asked the Dean's office to forward to all international students the survey. We are conducting the survey how you are using the complementary and alternative medicine. Did you fill it? Okay, thank you. Hopefully we will have great results and we'll publish them soon. If you have any question, you can ask. Yes. We can stop. And if you have a question of the sport as well. One minute. Рано через свежо. Говорит, конец уже такой усталый голос. У меня дочь закончила 6-й курс мединститута, она меня слушает.
Good morning, dear students, our professor. We're glad to welcome you to our lecture, and we hope that this lecture will be interesting and more new knowledge bring for you. If you have any questions, you can ask our professor. Welcome to start.
Thanks very much. Thank you very much for your kind introduction. Good morning again. Welcome. I am very pleased that there are such enthusiastic students and active ones and scientifically curious. Despite being the first 2-year students and not studying pharmacology, you are interested already. This is very good sign of your activity. And today is actually 4 as written here. It is just the continuation of our lecture 4, where we have started talking about the investigational agents for the treatment of COVID-19. And at the last lecture, I was emphasizing the antiviral drugs and different approaches for their development. And I have also begun the immunotherapies and different immunomodulating agents. How can we approach the cytokine storm and acute respiratory distress syndrome, which are very severe complications of COVID-19? And today I will continue our talk about these immunotherapies. As we said, one of the core cytokines is the interleukin-1 in the cytokine storm. And we call it also cytokine release syndrome. And anakinra also fortunately was used already. It was in the clinical use already for some autoimmune conditions. It is anti-interleukin-1, and by blocking the interleukin-1 action, it is useful and has been used now off-label. Off-label, it means it is not approved yet, but some doctors, because it exists in the clinical practice, they prefer to use this drug in COVID-19 patients. Another approach is interleukin-7 inhibitor, and it is called CYT107 or Rev-Immune. By inhibiting this interleukin, it causes T cell production, and T cells are very important cells. You know, probably you know from school or from the subjects at the first or second year that T cells are responsible for the cellular immunity, while the B cells, they're responsible for the humoral immunity and they produce antibodies. So here we enhance the T cell production, and this is very defensive against the virus. And several phase 2 clinical trials are undergoing now in France, Belgium, UK, to assess what is the immune response in lymphopenic patients with COVID-19. What is lymphopenic patients? One of the markers of the disease, COVID-19, is decreased lymphocyte count, lymphopenia. And by the way, this is not a good sign. This may indicate that disease will be severe. So if you find that the patient has lymphopenia, decreased lymphocyte count, and if we know that the drug can increase activity of the T lymphocytes, this is good. And hopefully in the future, the drug will be used. Of course, corticosteroids, I was talking about them many, many times. Corticosteroids are used in clinical practice very widely. They are very important medications as immunosuppressants, as anti-inflammatory drugs, anti-allergic drugs. And I was already mentioning that there was a big study conducted in the UK. It was called Recovery Study that assessed the mortality or the death rates at the day 28 in the hospitalized patients with COVID-19. They were giving low dose dexamethasone, which was 6 milligram PO, means orally as tablets, or IV, means intravenously, for 10 days. And this was added to usual care. Usual care at that time, what was the standard care at that time? Just giving oxygen and antipyretic drugs. There was no other treatments. And in the dexamethasone group, they noticed that the death rates were lower than in the usual care group. See, I have the numbers, 29% in the dexamethasone group as compared to 41.4% in the standard care group. and particularly among also including those receiving oxygen without invasive mechanical ventilation, but not among those who are receiving no respiratory support. See, in these subsets of patients, the difference was not remarkable. What is 23% versus 26%? Or what is 17.8 versus 14%? Very unremarkable finding, which resulted in the conclusion that the more severely is the patient sick, the more he will be benefiting from dexamethasone. See, those who received mechanical ventilation, they had remarkable difference. Those who just received simple oxygen support or did not need oxygen support, they did not benefit from this treatment. That's why came recommendation to use dexamethasone only in patients who have respiratory support, who need the respiratory support, particularly, as you can see, mechanical ventilation. That's why corticosteroids are very, very, they were called game changers. The game changer, they tremendously affected the disease course, and they have saved so many lives. And then there was a meta-analysis. What is meta-analysis? It is useful to explain here. Meta-analysis is when the scientists conduct analysis of many trials, okay? I know that there is one trial in South Africa, the other in India, the other in UK and the United States. All of them were conducted on a number of patients, but when we pool, we combine from the literature, all the statistical data from all these studies, we have much more patients. And you know that the more observations, the more confirming are the results, the more convincing are the results. And this is what they call meta-analysis. Okay, they did not conduct the studies themselves, but they found the results in the literature and they combined them. So this meta-analysis was conducted by the WHO. You know what is WHO, the World Health Organization. And they pulled data actually from 7 trials, including recovery that I have mentioned several times and other trials. And the total number of patients in this meta-analysis was almost 700 who received the corticosteroids and almost 1,000 who received standard care. And they found association between corticosteroids and reduced mortality. And they furthermore found that not only dexamethasone was effective, any corticosteroid can replace dexamethasone. For example, you can use hydrocortisone. So this is the class effect. This is not the effect of one particular drug from this class, but it allows us to use any other corticosteroid, as I said, hydrocortisone, prednisone, methylprednisolone, etc. And the 28-day mortality rate was the primary outcome. Usually when you conduct the study or the analysis, you decide what is your outcome. The most important or the most convincing are clinical outcomes. Do you care, for example, about the C-reactive protein level or the lymphocyte level or platelet level? What is all in all this information for you? The more important for you is to know how the deaths are prevented, the mortality rate, or how fast the patient will be discharged from the hospital. So the primary outcome was the mortality rate, the death rate after 28 days, and it was significantly lower, again, in this meta-analysis among corticosteroids, 32% versus 40%. Not that great difference, but it was statistically significant. That's why the corticosteroids, they take such a wide place in the treatment. In contrast to the convalescent plasma, we have explained several times what is convalescent plasma. You know that. What is convalescent plasma? Plasma that we take from the recovered people from COVID-19 and we transfuse it to the people who are severely ill with COVID-19. It was granted the emergency use authorization 1 year ago for hospitalized patients with COVID-19. As I explained, this plasma is rich in what? In the antibodies against the virus, because the person has recovered from the virus. Why he was able to recover? Because he produced his own antibodies. Now this antibody-rich plasma was given to the patients, and There are some differences in different guidelines. There are two main American guidelines for the COVID-19. The NIH, as I said, this is National Institute of Health. They evaluated the data from the Mayo Clinic. The Mayo Clinic is, as you know, is one of the leading clinics in the world. And they found that, okay, the convalescent plasma did not cause harm. In other words, there was no serious adverse effects, but it was unlikely to benefit the hospitalized patients. No usefulness. While the IDSA guidelines, which stands for the Infectious Disease Society of North America, recommends limiting use of high titer convalescent plasma only for hospitalized patients with COVID-19 to the context of clinical trial, which means that officially we cannot use the convalescent plasma only if the patient volunteered that, yes, I will be the part of the clinical trial. As a part of the clinical trial, yes. As a general approval, not yet, because they are not sure after the Mayo Clinic data whether this treatment is beneficial or not. So this is the place of the convalescent plasma. Regarding the interferons, I've mentioned that interferons are used intranasally in Russia, but regarding the other countries, the laboratory studies, okay, they support the use of interferon, they suppress the, the studies suggest that the people with COVID-19, they have suppressed interferon level. The virus switches off interferon mechanisms. The virus is very intelligent. Somehow it puts the interferon off. And that's why the scientists are thinking of using interferon even systemically, for example, intravenously, or at least by inhalation into the lungs. While in Russia, it is used by a spray in the nose or ointment. So in the laboratory, in the Western countries, interferon was shown to inhibit the SARS-CoV-2 and also to other dangerous coronaviruses that we know already, SARS-CoV, which is responsible for the Far East outbreak, and MERS-CoV, which is responsible for the Middle East outbreak. And there was a trial conducted to compare subcutaneous interferon beta-1a, Rebif. And here I would like to mention one thing. Rebif is already in wide clinical use for the treatment of some diseases. The main disease treated by Rebif is multiple sclerosis. Probably you have heard about this disease, multiple sclerosis, no? This is a very severe neurological disease. It affects the brain and the spinal cord. And this is a very progressive disease. Eventually, the person progresses to disability. He will be on the wheelchair as a result of damage of the central nervous system. So very, very severe disease, fortunately very rare. It is an autoimmune disease, multiple sclerosis, and it is very well known that interferon beta-1 or Rebif is beneficial in these patients, and many, many patients receive this treatment. So again, we were fortunate because this treatment is already available clinically. And there was a concern, for example, my husband, he's a neurologist in Jordan, and he is in contact with many multiple sclerosis patients. And in the beginning of pandemic, it was a big concern that people with the multiple sclerosis, because they are already having impairment in the immunity, they may die more frequently from COVID-19. But fortunately, because many of them receive interferon, they survive the disease even better than the normal individual, from which came the observation that interferon, because it is defensive antivirally and it is immunomodulator, can be used in the clinical practice. And it was added to remdesivir, and it was compared with remdesivir plus placebo. What is placebo? You know what is placebo? No? When we conduct the clinical trials, we always compare the treatment with no treatment. But, you know, in medicine, it is very well known that if you just give the pill, just pill with glucose or pill with the salt containing sodium chloride. This may produce some psychological effect on the person. He believes that he's receiving the treatment from the doctor and he may simply psychologically improve. This is called placebo or dummy. Dummy, it is empty. It does not contain the drug. Or if the treatment is injection, okay, the treatment group receives the injection of interferon subcutaneously, as we said. The other group should also receive something subcutaneously, at least water or normal saline, because just injection may cause plausible effect and particularly important for CNS diseases. And that's why when we are talking about the placebo, this is always the component of the clinical trial. So one group received interferon plus remdesivir, the other group received remdesivir plus placebo, some neutral injection, not a drug. And so this trial is ongoing, and hopefully it will show positive results. And it is anticipated to enroll over 1,000 patients in different 100 sites across the United States. Now, other interesting therapies. There is inhaled nitric oxide. Inhaled nitric oxide is a gas, and in some clinical guidelines, it is included because, inhalation of nitric oxide causes pulmonary vasodilation, which means it widens the vessels in the lungs. And this is this was used in several clinical trials because you know what happens when the lung is damaged by the viral pneumonia. As we said, there is acute respiratory distress syndrome. There is inflammation, there is accumulation of fluid and cellular debris, which means we have dead cells accumulating in the lungs. Is there effective exchange of oxygen in the lungs? No. So the blood does not receive sufficient oxygen. So the body experiencing hypoxia. That's why when we measure the oxygen saturation, we find it low in COVID-19 in severe cases. Okay, so the idea was to give inhalation of nitric oxide to dilate or widen the vessels in the lungs. Okay, you have poor oxygenation, but at least if you improve the blood flow to the lungs, there is hope that more oxygen will enter. So there were some clinical trials, and also it was noticed that nitric oxide modulates the immunity, and currently some are conducting trial only. So currently it is in the clinical trial only. In whom? In mechanically ventilated patients. With what? With severe acute respiratory distress syndrome, or ARDS, and hypoxemia, because we want to dilate the lung vessels, as we said. And it is very expensive. It is more than $100 per hour of inhalation. Other interesting therapy, and this is another important example how we are repurposing the drugs. As I told you, repurposing the drugs is knowing that this drug is used for a long time in the clinical use for other diseases, but noticing that there is some beneficial effect, either antiviral or immunomodulating. You know, statins. Statins is the class of drugs that are probably the top prescribed drugs in the world. If you compare in the pharmaceutical market, this is the top prescribed class of drugs. Why? Because they are used to lower cholesterol level in the body. And we have so many people with cardiovascular diseases who need to lower their cholesterol level in order to prevent myocardial infarction, cerebral stroke, etc. So it was long ago noticed that in addition to lowering the cholesterol, the statins, which act by the HMG-CoA reductase inhibition, okay, statins are able to decrease the inflammatory cytokine production. As you can see here in the by the purple or violet actually arrows, sorry, by controlling certain processes, by controlling the nuclear factor KB in the nucleus, we modify the DNA transcription, and furthermore, there will be no RNA translation, which encodes for the inflammatory cytokines and chemokines. No cytokines and chemokines, no cytokine storm. So the statins may be beneficial, and there were 2 meta-analyses, and unfortunately, they showed opposing conclusions. One showed positive result of statins, the other meta-analysis showed no effect. That's why more trials are needed to answer this question. So potentially statins are effective. What happens in the real life? We always need to prove conducting the clinical trials. All right. Next interesting immunotherapy is busilamine. Busilamine is also anti-rheumatic drug. As you could see in the earlier lectures, we have many drugs from rheumatoid arthritis treatment. We have already mentioned the interleukin-6 inhibitors, such as tocilizumab, and this is another anti-rheumatic drug. And actually, this drug presents, it is a derivative of N-acetylcysteine. Yes, please unmute your microphone, Ahmed. Okay. Please mute your microphone. Mute your microphone, please. So N-acetylcysteine and busilamine is derivative of N-acetylcysteine or NAC, as you can see in this image. Что-то со звуком у нас нет? Все нормально? Вы выключили, отключили микрофон у студента? You can see here, let me enlarge the image. I cannot enlarge the image currently. Okay, look at the red arrows. You can see that the NAC, which is N-acetylcysteine, inhibits the release of the pro-inflammatory cytokines, and on the other hand, it promotes the, actually inhibits the oxidative stress. So we can say it is antioxidant and anti-inflammatory agent. And it has 2 thiol groups. So we can say that this is a thiol donor, 16 times more powerful than the NAC itself. And currently it is in the phase 3 trial for the treatment of outpatients. We will use it in the outpatients with mild to moderate disease. And it is planned to start, it is already started in 2021, Q1. Next interesting approach is to use the MK molecule, MK7110 from Merck company. Merck, as you know, it is one of the leading companies. And formerly this molecule was called CD24FC. It is actually an immunoglobulin molecule. If you look, простите, а можно сделать экран активным, чтобы я могла увеличивать? Когда я дотрагиваюсь, у меня зум не получается. Да? Нет? Вот так. Спасибо. If you look at this molecule, it is Y-shaped, the shape of Latin Y. And this is a classically immunoglobulin molecule. As you probably know from the biology, it is containing long Fc fragment shown in gray and 2 short Fab fragments, which are CD24 shown in green here. So this molecule binds to the dump certain patterns, damage associated molecular patterns. This happens at the level of the toll-like receptors. I explained to you previously, toll-like receptors are expressed on the surface of the innate immunity cells, for example, lymphocytes, and blocking the toll-like receptors by binding this molecule prevents the subsequent intracellular signaling, which results in the inflammatory cytokine. So we prevent the inflammatory cytokine by binding to the toll-like receptors. And currently there was interim analysis of the data from the phase 3 trial showing that a single dose of this molecule showed a 60% higher probability of improvement, which is very good. And the risk of death from the respiratory failure was reduced by more than half. And this is a very good clinical result. Next immunotherapy is the allogenic natural killer cells. Probably you are aware that some types of cell therapy is used in the treatment of many, many diseases. We grow the cells and then we inject certain cells and we treat cancers, we treat some inherited diseases, and we treat also COVID-19. So these are natural killers, as you know, the natural killer cells. They're obtained from certain progenitor pool, and when they are grown, they produce cytotoxicity, and cytotoxicity is very essential for the killing of the virus. And there was a range of biological activities demonstrated for the NK cells. And this is currently in the clinical trial. Other therapies include AD669. Please mute your microphones. Mute your microphones, please. Okay. This is the inhibitor ADX629 is the inhibitor of the reactive aldehyde species. This reactive aldehyde species, like reactive oxygen species, are generated when there is activation of the macrophages, neutrophils, and other cells of the innate immunity. And blocking these species, as shown here by the X arrow, prevents the cytokine release syndrome, and this means that we prevent the respiratory decompensation or respiratory failure, which is the leading cause of death in COVID-19 patients. And currently, the placebo-controlled trial, we know what is it, is in phase 2 in hospitalized patients. Another type of stem cells that can be used is the multi-stem cell therapy from the company Athersis. And these MSCs, multi-stem cells, as you can see in the diagram, they may produce the inhibition of the cytokine release, including HGF, VEGF, which are endothelial factors and growth factors of different types. They restore the epithelial permeability. Sorry, they do not block. In this case, they favor the release of the useful cytokines, such as these growth factors. They protect the endothelial barrier. And endothelial damage is also very essential. I told you that the ACE2 receptors are present not only in the lung cells, and these receptors are the target for the virus, but they are widespread in the endothelium. Endothelium, I repeat, is the inner lining of the blood vessels. So the damage to the endothelium causes thrombosis, and thrombosis is another serious cause of deaths, myocardial infarction, cerebral strokes, amputations of the extremities. I told you previously about that. This is all because of endothelial damage. Endothelial damage triggers thrombosis. What is thrombosis? Formation of the blood clot, ischemia of the organs, no blood delivered to the organs, vitally important organs. So it is very essential to restore the endothelial cells function through these growth factors, HGF and VEGF, to restore the epithelial permeability, because in this viral infection, epithelial permeability is enhanced or increased. And normally there should be no gaps between the alveolar epithelial cells. See in the middle, this is the alveolar epithelial cells. There should be tight junctions between them. But if the cells are damaged, there is opening of the gaps and the shift of the fluid into the neighboring space from the blood vessels to the alveoli and to the neighboring spaces. That's why the patient develops pulmonary edema and he cannot breathe. Basically, this is acute respiratory distress syndrome. And it will be very, very useful to restore the epithelial permeability, to restore these tight junctions. And also there are certain factors released by the exosomes from these cells that we transfuse to the patient. And these factors from the exosomes, they protect the ACE2 receptor from binding the virus. They inhibit the apoptosis of the endothelial cells. What is apoptosis? You know what is apoptosis? Programmed cell death. So inhibition of apoptosis, no death of the cell. We prevent the loss of the cells and the suppression of the inflammation that happens in the lung through the certain molecules, MIR, with different numbers. So this is another cell therapy. Cells are given, and previously phase 1 and 2 studies, it was assessing people with acute respiratory distress syndrome. And now the first patient has been enrolled in the phase 2/3 trial at the University of Hospitals Cleveland Medical Center. Cleveland Clinic is another leading clinic in the world. So now they are in the phase 2/3 clinical trial with these cells. As you can imagine, this is very expensive therapy and it is not used deliberately in any patients. We select only very severely sick patients who are in the respiratory failure. Next investigational immunotherapy is foralumab, and it is given intranasally. You can see the structure of this antibody. Basically, you are familiar with the Y shape of the immunoglobulins or antibodies, okay? You can see the structure of this. Actually, it is immunoglobulin of G1A+, fully human antibody. This antibody is directed against the CD3 molecule, and CD3 molecule is the part of the complement, it is the part of the T cell system. And this results in inhibition of the interleukin 10. And this drug is being investigated in Brazil. In Brazil, it will be used intranasally, as I told you. Next drug is PEG interferon, and I was already talking about the interferon and the Rebif and its place in the treatment of multiple sclerosis and how did it improve the outcome of the multiple sclerosis patients. So from these observations, PEG interferon is basically the pegylated interferon where the polyethylene glycol is attached to the interferon molecule, and this allows us to prolong the effect of interferon. So like instead of 3 times a week, the person receives just once a week injection because we have longer duration of action. Otherwise, it is the same. I will not go into the details. The PEG interferon lambda has now been investigated since May and ended in September last year in outpatients by subcutaneous injection. And it was able to suppress the viral load. This slide just to show you how the interferon is acting. We are talking about the interferon alpha lambda. Please look at the middle of the slide. Interferon, can you see the IFN alpha lambda? Okay. It acts through the JAK kinases. JAK kinases, we have discussed the role of this intracellular signaling mechanism when we were talking about baricitinib, one of the JAK kinase inhibitors. Through the STAT2 and STAT1 molecules, this modifies the nuclear response, and this further affects the genes that are responsible for the encoding of the cytokines and the chemokine production. So suppresses the immune response, exaggerated immune response. This is the place of interferon therapy. Next, the immunoglobulin IV, IgIV. Approved also in the Russian guidelines. It exists firmly in the Russian guidelines. And the pilot study conducted with the IVIG plus IV methylprednisolone IV intravenous, all right? Methylprednisolone, as I told you, analog of dexamethasone, one of the corticosteroids. And it significantly improved hypoxia and reduced hospital length of stay and progression to mechanical ventilation. It is very, very important. Because you know that if the patient reaches mechanical ventilation with COVID-19, the prognosis is not actually very, very good. Majority probably of people who reach the mechanical ventilation are dying because they already have acute respiratory distress syndrome. So prevention of progression to mechanical ventilation is something very great. And it was shown to be positive. And now there is a phase 3 multi-center randomized double-blinded clinical trial underway to validate these findings. I want to say some few words about the IVIG and its place in the treatment of children with COVID-19. You know that fortunately children are having either asymptomatic infection or they are having very, very mild disease, fortunately. But now, particularly with the new mutants, some children develop the multi-system inflammatory syndrome, MIS, multi-system inflammatory syndrome, which means that they have widespread inflammation and many, many systems of their body are affected, and it is very, very severe and deadly. And it looks like Kawasaki disease. Kawasaki disease is an autoimmune condition that affects the heart. There is damage to the heart muscle, damage to the vessels. So these children suffer very, very badly from this syndrome. And one of the main treatments for the MISC, which is, I repeat, multi-system inflammation in children, is the IVIG. But it is not mentioned here. How does the treatment work? By the scavenging of the complement, by the regulating the effector T helpers and T helpers 1 and 17 regulatory T cells, and inhibiting the innate immune cell activation and secretion of inflammatory mediators. Okay, next drug is the interleukin-7, and I believe I was mentioning already interleukin-7. Interleukin-7 plays a key role in the T cell development, as you can see from the image. Binding to the interleukin-7 receptor, it regulates the certain intracellular signals, including STAT5 and PI3K through its specific receptor. And this receptor is expressed on the naive and memory CD4 and CD8 plus T cells, promoting the proliferation of these cells. Proliferation is multiplication, maintaining and increasing the functional ability of these cells is very essential to attack the virus. And currently we have the phase 1 trial initiated by the University of Nebraska in the United States. So I would like to mention also the interleukin-17 inhibitor, actually, that was mentioned by me in the lecture number 3, when I was talking about the clinical protocols used in Russia. In Russia, they use also interleukin-17 inhibitor, but it is not presented in this overview because I have taken it from the Western sources. Next one is vilobelimab, or IFX1. It is first in class monoclonal anti-human complement factor C5a antibody. As you can see, this factor interferes with the complement system. The complement C5AR inhibitor is blocked, and actually this particular molecule is not demonstrated here, but the net result is the suppression of the inflammation, amplification of the phagocytosis, and other beneficial effects. And phase 3 trial was initiated last year for the severe pneumonia related to the COVID-19. Another type of cell therapy, so far we know the use of the NK cells, which are natural killers. We have discussed the MSCs, multipotent stem cells, and now we talk about the allogenic virus-specific T cell therapy, which means that these T cells are already trained against the coronavirus. It targets specifically SARS-CoV-2 virus, and it comprises almost exclusively which subset? CD3 plus T cells with a mixture of cytotoxic CD8 plus and helper CD4 plus cells. All right, so we have a mixture of different T cells, mostly 3 plus type, and phase 1 trial is undergoing in whom? In, again, very severely sick patients who are hospitalized and have high risk for mechanical ventilation. So this is just the interaction that is shown for the exogenous stem cells. We have different types, mesenchymal and stem cells and virus-specific cells that are of interest for us. I cannot enlarge this image again. To the lowest part of the left panel, virus-specific CTL cells, they kill directly the virus that is presented in the lungs. And we have other approaches, salivary gland epithelial cells, dilated cells of upper respiratory tract, lung stem cells that are all going to be used in the future. Inhaled beta interferon, beta 1A interferon is in the clinical trials, while another inhaled interferon, or actually intranasal interferon of alpha type is used intranasally in Russia, but this is beta type used by inhalation into the lungs. And interferon beta, I already explained several times that one of the observations in COVID-19 patients is that they have deficit of their endogenous interferon that cannot fight the virus. So this predisposes to more severe respiratory symptoms among particularly elderly and at-risk patients. And it is believed that the inhaled interferon beta 1A will help to restore the lung interferon beta 1 ability to neutralize the virus. If we give by inhalation, it will produce local effect in the lungs. And positive results from a phase 2 study are now continuing in the UK into the phase 3. And another intranasal immune modulator called T-COVID or autoimmune. It is in phase 1 and 2 trial in US for non-hospitalized patients. Of course, the intranasal therapy is used with mild, in people with mild infection. I will not talk about the antibodies granted emergency use authorization. I was talking about them in the guidelines. And there are other, many other antibodies similar to those that I have discussed, the anti-SARS-CoV-2 antibodies. So a large number of other antibodies are now in the clinical trials or preclinical stage. And I would stop here because we have to make a break for 5 minutes. Okay. If you have any questions, you can ask. I think maybe we will have them. Are these photos for the Facebook page? Yes, ma'am. Okay, thank you. Tell them that I will stop receiving responses after tomorrow, because after tomorrow lecture I will be explaining these therapies, and it will be biased if after explanation the questionnaire will be answered. So it should be done before I explain the use of these therapies. Pardon? How Sputnik is prepared? Okay, this is one of the 4 platforms for the coronavirus vaccines, as I explained in my second lecture. It is the adenovirus vector, genetically modified, or we call it genetic engineering. We choose the adenovirus that is not infected for the human. And we insert into the genome of this adenovirus the gene that encodes for the S protein of the, so we are playing with the genes of the adenovirus. We inserted the piece of the gene that will encode for the S protein. As you know, S protein of the virus is the protein responsible for the attachment to the humans. Okay, now we have this modified adenovirus. When we inject it to the human, it's because the gene is present that encodes for the S protein. Our bodies start generating, our cells start generating S protein. As if we are virus, we generate S protein. Now, because this S protein is foreign for our body starts producing antibodies against S protein. This is what we want, because this is the basic antibody against the virus. If the virus in the future comes to your body, the antibody is ready and it will attack the virus, preventing its attachment. Why 2 doses? Interesting. The 2 doses are different. The first dose is one adenovirus and the second dose is another type of adenovirus. This is in order not to have the immune response against the adenovirus itself. So a little bit complicated. Imagine you gave the same second dose. If you give the same second dose, which is happening with the AstraZeneca, I don't know, an AstraZeneca vaccine, which is similar platform, but they use a chimpanzee adenovirus, not human one. One of the doses is chimpanzee. Sorry, no, get my last sentence. So the idea of giving the different second dose is not to have the antibodies that will reject the second dose. In a simple way, when the first dose is received, we have not only antibodies against the S protein, but we also have the antibodies against the adenovirus, right? Because it is also a foreign body for our organism. So if you give the second same dose, it will be rejected. But if the virus, adenovirus, is different from the previous one with the second dose, you have still immune response. Yeah. A good question. You are vaccinated how many days ago? On Friday. The first dose or the second? The first one. Basically, there is no interference with medications. Of course, alcohol is prohibited. Alcohol may reduce the immune response development, and immunosuppressants. It is better not to receive the vaccine while the person is on immunosuppressant, for example, corticosteroids or another immunosuppressant for somebody who is suffering from autoimmune disease. So it is better to give the vaccine not during the immunosuppressant. Or still the vaccine will be used. I'm sure they will use vaccine, but there might be fear of reduced immune response because there is immunosuppression. There will be no full development of antibodies. There might be no defense or decreased defense. Other drugs,
post vaccine?
Yes, there is no absolute protection. With none of the vaccine, there is absolute protection. But it is believed that the disease will be milder and we prevent the risk of hospitalization and deaths. And this is the major outcome. I told you about the clinical outcome. Do we care about being infected in general? No. We care about the severe forms of the disease and the death, right? Of course, we care also about the being infected in general because we fear that, okay, you are vaccinated, but you might still spread the infection because you are having asymptomatic or a mild disease. That's why we cover as many people as we can with the vaccine to prevent also the spread of the disease. Suppose the other person I know, he has contraindication to the vaccine because he has severe allergy in the past. You know, people with severe allergy, or this person is with cancer and he is receiving cancer chemotherapy. This is contraindication to administer the vaccine because vaccination will interfere with his cancer. We are responsible for those people as well because we may spread the infection. That's why this is the second reason why we should become vaccinated, to protect the other people, not only to protect ourselves. Right? Other questions? Okay, let me talk some more about interesting potential investigational immunotherapies. One very interesting drug, I don't know why it is included in this table that contains antibodies, but I have highlighted it in red. It is the camostat mesylate. It is not actually the antibody, but it is orally effective transmembrane protease serine 2 inhibitor, TMPRSS2 inhibitor. If you remember in the very beginning of the lectures, I was showing you several times this serine protease together with the ACE2 receptor. They are responsible for the attachment of the virus, the very initial step of invasion of the cell. So if you block this serine protease, as if we block the ACE2 receptor, we prevent what? Entry of the virus into the cell, and the earlier we interfere, we know, is the better. When we interfere with the earlier steps, there is still no damage of the cell, but when we interfere with the final steps of the viral replication, this means that the cells are damaged and many newly formed viral particles are released and they infect the other cells. So this is a very promising treatment, I believe, and currently this is a phase 2/3 trial conducted by the National Institute of Health, NIH, called the Active-2 protocol. Another promising molecule I have encircled also here or highlighted is LY-CoV1404 by Eli Lilly. As you probably know, Eli Lilly is one of the leading manufacturers of insulin. Actually, basically, it is one of the two manufacturers of insulin in the world. So they are dealing with the large molecules. They are familiar with the large molecules, and they produce the antibody that binds. Okay, we know many antibodies that bind to the spike protein. I have repeated several times, we have 5 antibodies already in clinical use, at least in the United States. One of them is Solar, the other has been discontinued because it was shown not to be effective against new mutants, and the other couple is still in clinical use. What is particularly remarkable about this new promising antibody is that the preclinical data found that it binds to a rarely mutated region. Okay, we have mutations in some regions, but there is a conserved region which is not changed by mutation. So the importance that this antibody binds to this region of the spike protein, and this allows to neutralize all currently known variants of the virus. Whatever we know variants, this antibody will be effective, hopefully, including the UK, Brazil, California, South Africa, New York strains, and it will be part of the BLAZE-4 clinical trial. Probably they are investigating it in Delta virus, but theoretically it should be effective because, as I told you, it deals with the highly conserved region which is not changed by the mutation in the spike protein. Is this clear? Okay. Next approach is actually to suppress the cytokine storm. If the person is not severely ill, why should we care? The disease is mild to moderate in majority of cases. But if the person has severe disease with the cytokine storm, as we already know, it results in the acute respiratory distress syndrome, when the patient cannot breathe, cannot oxygenate his body. And we will talk about drugs for such syndrome, for such cytokine storm now. One of the approaches is to use the human vasoactive intestinal polypeptide. This polypeptide shown actually in why I'm touching and I cannot zoom it. Shown in black structure on the surface of the cell. Okay. This vasoactive intestinal polypeptide in black prevents the NMDA-induced caspase-3 activation in the lungs, and it helps in the oxygen transfer. It prevents the hypoxia, and blocking this receptor will block the cytokine storm and ARDS. And we have the results of trial in its final stages, 2B3 trial of intravenous drug. Drug is called aviptadil. I repeat, that blocks the VIP. VIP is not very important person in this case. It is the vasoactive intestinal peptide. So this drug binds the VIP molecule, and it is effective in respiratory failure in critically ill patients with COVID-19 because it suppresses the hypoxia and cytokine storm. And very impressive results is that these people who received the drug were already having respiratory failure, meaning that they already received remdesivir, corticosteroids, anticoagulant drugs, various monoclonal antibodies, and it was not helping. But when this drug was added, the increased recovery and survival was observed in patients who already had respiratory failure, I repeat. And also it is now being studied as inhaled formulation. So we will have both intravenous when you reach the lungs from the systemic circulation, and inhaled when you reach the lungs from inside the bronchi. Colony stimulating factors. I believe we have talked about it a little bit, and here I will focus on lenzilumab, which is a monoclonal antibody directed against GM-CSF. GM-CSF is the granulocyte monocyte colony stimulating factor, and results from a phase 3 trial found this molecule also to improve survival without ventilation. These people did not need ventilation when they were hospitalized, hypoxic, and this treatment was, of course, also added to remdesivir and or corticosteroids. And the most improvement was shown in people who had C-reactive protein, CRP level less than 150 milligram per liter and were younger than 85 years. So this is to show how lenzilumab blocks the GM-CSF action on the myeloid cells, and myeloid cells give us macrophages and neutrophils and other cells that release a number of cytokines that you already know, different types of interleukins that are responsible for the cytokine storm and other complications. As you can see, these cytokines are responsible for hypotension, ARDS, myocarditis, multi-organ failure, disseminated intravascular coagulation with thrombosis and neurological changes. All this is prevented by blocking the GM-CSF by lenzilumab. Similarly, and interestingly, we are talking about the CSF antagonist or blocker. But on the other hand, other approach is to use actually these colony stimulating factors, not to block them, but to use them. And one of these factors is sargramostim. It is also a very well-known drug that increases the number of macrophages and neutrophils. And inhaled sargramostim in phase 2 trial was shown when it was added to the standard of care, SOC. These people had acute hypoxemia and they required supplemental oxygen. They improved oxygenation from baseline significantly, and secondary infection may also reduce. So the proposed mechanism for this granulocyte macrophage colony stimulating factor, GM-CSF, that it binds to its receptor and it activates the specific cells, macrophages, neutrophils, dendritic cells, and monocytes. So block is shown in red. This is blocking effect. Red is blocking effect actually. So when we give this factor, sargramostim, we actually block the activation of these receptors, and we block also the JAK-STAT pathway that we know already. We have mentioned that several times. All this is responsible for the generation of the cytokines and inflammation. So we prevent all these events. And I repeat, it is used inhaled, as inhaled form. Other colony stimulating factors being studied also are gimsilumab, mavrilimumab. They are all GM-CSF given by different routes. I will not go into details about this colony stimulating factors. Even other drugs were shown to be effective. For example, tradipitant. Tradipitant is the antagonist of the neurokinin NK1 receptors. Sorry. And we know that this class of drugs are actually used as antiemetics. What is antiemetics? They are used in the treatment of vomiting. Particularly, vomiting is severe, as you probably know, in patients who receive anti-cancer drugs. Anti-cancer drugs, cancer chemotherapy, you know, one of the most dreadful effects in these patients is vomiting. So NK antagonists are recently approved for the treatment of such vomiting. And interestingly, the NK receptor is also located on the different other types of cells. For example, in the T cells and in the neurons, we know that the neurons also, they contain the NK1 receptor to the substance P. SP is a very important substance in the neurons, responsible for the transmission of the pain. And talking about the immune cells, the activation of the neurokinin NK1 type receptor by substance P triggers the intracellular events that result. The net result, interesting for us, is the chemokine and cytokine production. So by blocking this pathway, this receptor, we block the subsequent signaling mechanisms and we prevent the activation of the cytokines, and this way we prevent serious lung injury after viral infections. And there was Odyssey phase 3 trial in severe or critical COVID-19 infection patients. Those who received tradipitant, they recovered earlier than those who received placebo. Mesenchymal stem cells, this is another example how other cell therapy may be used. Remestem cell is allogenic mesenchymal stem cell product currently pending approval for another disease, graft versus host disease. I will not go into detail about this disease. It happens in the patients who receive bone marrow transplantation, you know. For the treatment of some blood cancers, such as leukemia, we use transplantation of the bone marrow, and in graft versus host disease, unfortunately, the transplanted bone marrow because it is immunocompetent. It contains many immune cells. It attacks their host, the body to which we transplanted the bone marrow. And that's why, fortunately, we have this drug. And this drug now was tried in the treatment of ARDS in COVID-19. And fast track designation is granted if a therapy demonstrates the potential to address unmet medical needs. In other words, if it will be successful, then it will be in the clinical use. You can see how the mesenchymal precursor stem cell may reduce the cytotoxicity and cytotoxicity and activation of the dendritic cells and macrophages. And this means that we prevent the release of particularly interleukin-10, as shown in this slide. Now, we said that if this treatment will be successful, it will undergo fast track approval. And at the end of the previous year, the phase 3 trial in ARDS patients has enrolled about 200. And the goal is to enroll the 300 ventilator-dependent patients. So this is the most severe subset of the patients with moderate to severe disease. And it is ongoing, the trial, and the primary outcomes will be the discharge from the hospital, and this will be after receiving 2 intravenous doses of the drug. Some other types of mesenchymal stem cells are also in phase 2 trial. The PLX-PAD and BM-ALLO-MSC is in phase 1 trial. All of them are being investigated. We have a number of others. So all this is the same idea, to downregulate the cytokines. Next approach is to inhibit the phosphodiesterase. Phosphodiesterase enzyme is very essential. Probably, you know, the drugs such as theophylline and even caffeine that we drink every day with tea or coffee, they all act by inhibiting this enzyme phosphodiesterase. But there is a particular subtype of the phosphodiesterase. Phosphodiesterase is abbreviated as PDE. Subtypes of our interest in COVID-19 are subtype 4 and 10. And we have the molecule called ibudilast. It inhibits not only phosphodiesterase, but also migration inhibitory factor MIF. All this suppresses the pro-inflammatory cytokines and promotes the neutrophilic factors that activate the neutrophils. Okay, so this is where phosphodiesterase E4 in oval, in purple oval, is shown. And by inhibiting this phosphodiesterase 4, we reduce the level of 5-AMP, which is 5-adenosine monophosphate, very important second messenger in the cell. Usually this second messenger activates the cell. If you block it, there is no cell activation and there is no release of the inflammatory cytokines. The drug has been approved already in Japan and South Korea. In other conditions, since 1989, it is used in post-stroke complications in bronchial asthma. And now in the United States, the investigational new drug application for a phase 2 trial to prevent ARDS has been accepted. Another phosphodiesterase inhibitor is apremilast, also blocking the phosphodiesterase 4. As we said, the specific enzyme for cyclic AMP, and increase actually of intracellular cyclic AMP level happens, not the decrease, as I said, which may directly modulate the production of inflammatory mediators. And this molecule is part of the SPY COVID-19 clinical trial. Now, next molecule is NMDA receptor antagonist. NMDA receptor is the receptor for glutamate. Glutamate is a very, very important molecule in the central nervous system. It is major excitatory neurotransmitter in the brain in particular. And this means that In pharmacology, you will study many drugs affecting this system. The new molecule, ifenprodil, which is also an NMDA receptor blocker or antagonist, is linked to inflammation. So when we block this receptor, as you can see, okay, it is shown in red. Ifenprodil, it blocks the action of glutamate on NMDA receptor. We prevent pro-apoptotic cell signaling, and also we prevent the mitochondrial injury, reactive oxygen species, which is ROS generation, and cell death. And this means that we reduce the inflammation. And now the drug is tried as injection and also as long-acting oral product to begin clinical trials in COVID-19 and acute lung injury. And they complete enrollment, and they will measure the oxygenation in the patients treated with this drug. Another approach is to use the esolizumab that prevents the formation of the membrane attack complex. Esolizumab, as you can see in the lower panel of the figure, and also ravulizumab, they block the C5 component of the complement system. And the complement system is essential in the immune attack. If you block this C5 component, the terminal part of the complement system will be also blocked. And this means that we prevent the cell lysis. Lysis, it means destruction of the cell. This is what we have in the lungs with severe COVID-19. So we prevent the lysis of the cells and other types of tissue damage. The first drug is now in the single arm trial. Of course, single arm trial is not very good design because, as I told you, we have to use the placebo for the comparison. But this is single arm trial, which means that they are using only the treatment and see how the patient will benefit. But then after that, the next step will be a randomized control trial where we assign the patients randomly to the treatment and to the placebo group. And the second compound is already in the phase 3 RCT, randomized control trial, in hospitalized adults, of course, with severe pneumonia or acute ARDS who require mechanical ventilation. Unfortunately, this second treatment was paused in January 2021. See, not all drugs are fortunate. By giving more and more examples, I try to show that, okay, theoretically, this compound should be very effective. Or even the in vitro or preclinical studies show good results in animals or in the cell cultures. But when we go to the real life, and why should we always conduct the clinical trials? We see that the drug is not effective or the drug is not safe. This is what happened with ravulizumab. So initial outcomes were not showing efficacy, but there is another phase 3 trial, TACTIC-R in the UK, is studying the use of early immune modulation in preventing the disease progression. Maybe in that unfortunate trial, they were using the drug too late. As I told you, with viral diseases, the earlier you use, the better the therapy. And next drug is the ATYR drug. It dampens the immune response as well by interfering with the molecule called the neurophilin 2, shown here. Unfortunately, I cannot enlarge the slide, but if you look at the lower panel of the slide, you see the abbreviation, the NRP2 molecule is blocked, and this downregulates the cytokine and chemokine production and T-cell activation, stabilizing the lung, reducing the inflammation of the lung. It is in phase 2 randomized double-blind placebo-controlled trial in more than one center in the US. So fortunate, hopefully the results will be fortunate. Next treatment is docetaxel. actually this glycosaminoglycan derivative of heparin. Heparin is a very well-known molecule. It is used as a drug, as anticoagulant in many, many patients, not only in COVID-19. Since I was a medical student, heparin was used as anticoagulant. Now, heparin is very close to the dosiprastat, and we know already, since long ago, we know that heparin is anti-inflammatory, not only as anticoagulant. And particularly, dosiprastat will be helpful in the lung impairment, where we have the impaired oxygenation. It was shown to improve the oxygenation by binding to the specific receptors. You see the drug is abbreviated as DSTAT, DSTAT, and you see in the right panel of the slide the green, I believe green, what do you call it, rectangular shape. The drug binds with the particular molecules HMGB1, reduces the release of the inflammatory cytokines, chemokines. We have many, many other approaches. Opaganib, which is orally administered, sphingosine kinase 2 inhibitor. Sphingosine kinase inhibitor is, you see the star in the figure, the big blue star that I have added to the slide to show the molecule, which is the target of this drug. So when we inhibit this sphingosine kinase molecule 2, this will inhibit viral replication, and also it will reduce the level of interleukin 6 and TNF alpha. As you remember, these molecules are the core cytokine molecules involved in the cytokine storm. So this molecule actually has two actions on the virus itself and on the immune response, and non-clinical data are convincing, and that's why the drug is now in the phase 2/3 trial. It enrolled a significant number of participants, and of course, these should be hospitalized patients with already pneumonia and who require supplemental oxygen, because currently we are talking about the drugs used for the ARDS. So we should select the most severely sick patients who have already ARDS to see whether these treatments are effective or not. Tranexamic acid, also a very old drug. Since I was the medical student, this drug was used as actually a hemostatic agent, which means that we used it to stop bleeding. For example, surgery, bleeding during surgery, we give tranexamic acid to stop the bleeding. Why it stops the bleeding? The other name of this drug is aprotinin, see in the blue here, aprotinin. It is a protease inhibitor, can be used orally or enterally to preserve the GI tract integrity and protect organs from proteases leaking from compromised mucosal barrier that can lead to ARDS. And this is a very interesting theory. You know that I will try to present it in a simple way. COVID-19 is not a lung disease only, as I tried to explain in my previous talks. It is a systemic disease, not only because the endothelium is involved all over the blood vessels, all over the body, but also because the virus is also swallowed. Okay, it penetrates through the nasopharyngeal mucosa, then it descends into the airways, but also it descends into the gastrointestinal tract because we swallow the virus. It damages the gastrointestinal mucosa or GI mucosa, increasing its permeability, and this favors the penetration of many toxins, and this sustains the acute respiratory distress syndrome because we have the toxins absorbed from the GI tract. Why? Because of penetration, increased penetration for these toxins. So it is essential to block these oral enteral proteases at several levels, as can be shown here. We blocked also the kallikrein bradykinin system, which is essential for the inflammation and permeability of the mucosa. So many targets here. First of all, you can notice also that aprotinin or tranexamic acid affects the virus as well. You remember my favorite serine protease, which is TMPRSS2 serine protease that was target also for other drugs that I was mentioning, that helps the spike protein to be attached and the virus to be fused with the membrane of the target cell. So we can notice that aprotinin blocks this protease in the virus, so it is antiviral. And on the other hand, by blocking the kallikrein bradykinin system, the fibrinolytic system, and intrinsic pathway of coagulation, major effect is systemic inflammatory mediator inhibition and cytokine storm inhibition. So that's why the tranexamic acid is now in phase 2 study that was announced more than 1 year ago, hoping that it will protect the organs from the proteases that leak at the compromised mucosal barrier. I can continue endlessly. I have maybe more than 100 slides, but it is impossible, and this is beyond the scope of this lecture. I was just providing to you many different examples how the scientists are working very hard to combat this life-threatening disease, and how the clinicians are trying to investigate in the real-life patients the work of these drugs for both prevention and the treatment, and for the treatment of very severe complications. I believe that I can stop here and not to exhaust you more, and the people online as well, but rather in the remaining 10 minutes to provide you with the opportunity to ask me questions. Let us interact. Maybe we have questions now. Thank you. Any questions here in the classroom? Think about questions. Maybe I can take a few questions from online students. Can you hear me well? Do you like to ask me any question? Not necessarily about today's lecture, anything regarding our past lectures as well, or you would like to ask about the disease?
No, thank you.
You're welcome. Okay, other students, please ask me. I was not mentioning other repurposing therapies, but just to provide you with more examples. Even antidepressant drugs, you know, depression is now widespread, and maybe after statins, the second top prescribed drugs are antidepressant drugs for the treatment of depression. If you compare the pharmaceutical market, first statins, then antidepressant. So one of the antidepressants, which is fluvoxamine, also was shown to be promising in the COVID-19, and it is also in clinical trial. Another very commonly used drug is famotidine for the treatment of the peptic ulcer disease. You know, many people, they're suffering from the hyperacidity in the stomach, from, you know, from the heartburn, and famotidine is one of the commonly used drugs. Also, it is now being investigated in clinical trials. So all drugs may be good for the new disease.
I just know they had asymptomatic COVID and they not take any
Medications.
and vaccine and nothing. I think. How it is possible to recover in just 15 days?
In just 15 days, how it is possible? This means probably that they have sufficient interferon and other antiviral molecules in the body, and good immune system response, that it handles the virus without symptoms from the.
How can it possible without medicine? They just has a quarantine.
Yes, this is what I'm trying to say. They have sufficient interferon, which is the antiviral molecule that is able to suppress the viral growth and to eliminate the virus without any treatment. This is ideally what we want. We want all our people to struggle the infection this way without having symptoms, just to eliminate it peacefully from the body by having good antibody response, by having good interferon. There is some theory that you know, I mentioned previously that in childhood, we had many coronavirus infections ourselves, right? But those were benign coronavirus infections. There might be some cross antigenicity, which means that we have antibodies to those coronaviruses which have some overlapping activity with the current coronavirus that may help us. But this is a very weak theory and needs confirmation. Yes, please. Plasma therapy. Yes. In one trial, it was shown not effective, maybe in more than one trial. And as I mentioned, there are other trials that are ongoing yet that are investigating this issue, and they might show that convalescent plasma may be effective. As I told you, in some countries, including Russia, the convalescent plasma is in clinical use. Yes. So this is not a very well-established issue. So we have contradictory information, as I said. And when we have contradiction from different studies, this means that we need to conduct more large-scale studies with larger number of participants, with better design. Better design, I mean, when you assign the patients to treatment and control group, which is placebo, you need to make sure that they are distributed fairly. Not like in the treatment group, we have younger patients with less diseases and maybe white ethnicity who respond better actually to the virus itself, not to the treatment. But if you distribute the age, the gender, the concomitant diseases, the concomitant medications very well, this is a very well designed study, and this will be more informative. As I told you, because the COVID-19 is the emergency situation, the currently ongoing clinical trials are not ideally designed. And that's why we have such contradictory responses from different trials, you know. So future studies will show better results, I hope.
Can I ask a question?
Yes, sure.
Today we talk about like stem cells. So
Yes.
my question is like stem cells can improve the outcome of ARDS in severe COVID-19?
Right, right. There are many countries that are conducting different types of stem cells. And as I mentioned briefly, the cells work by down-regulating the cytokine production. You know, we have negative feedback and positive feedback loops, including the immune system. Somehow we reduce the production of the cytokines when we introduce the stem cells. But as you could see, different types of stem cells are used. NK cells, the T lymphocytes, which are specific for this particular virus, the multipotent stem cells, and many, many different types of cells.
Thank you so much.
I hope I have addressed your question.
Yeah. Very good.
Okay.
Thank you.
You're welcome. The vaccine? No, so far there is no vaccines against the AIDS, right? This is the same story as I said for immunocompromised. Any immunocompromised person, whenever he is immunocompromised because of AIDS, or he is immunocompromised because he has genetic defect in his immune system, or he is immunocompromised because of cancer chemotherapy, or because of immunosuppression because he suffers from whatever autoimmune disease. Whenever immunosuppression is present, we might expect the reduced effectiveness of the vaccine. And by the way, I saw recent clinical trial results. Probably these people, they need a booster dose, which is revaccination, the third dose, I mean. And in some cancer patients, the booster dose, they produce good antibody response. So they need additional considerations, these people. Okay. Good question. Thank you. I like this group. They are very active. Thank you for coming and thank you for interaction. Yes, other questions? We have still 3 minutes, so maybe we have more online questions. No? All right, no questions here as well. Okay, thank you very much for coming and thank you very much for listening. And I would like just to remind you that those who did not participate in the survey, you can participate in the survey until my next lecture. The survey is about the complementary and alternative medicine use in prophylaxis and treatment of COVID-19. Because by the time I start the next lecture, this lecture will be about these therapies, I will close the participation. So if you are planning to respond by my next lecture, my last lecture actually, which will be about the complementary and alternative medicine. Maybe it will be easier, much easier than the previous lectures, and hopefully it will be more interesting for you. Thank you.
Большое спасибо.
Не за что. До свидания.
Thank you, ma'am.
Bye-bye.